Nursing management of the pregnancy at risk, selected health conditions. Pregnancy and childbirth are exciting yet complex facets within the continuum of women's health. Ideally, the pregnant woman is free of any conditions that can affect the pregnancy, but in reality, many women enter pregnancy with a multitude of health-related issues that can have a negative impact on the outcome. Diabetes mellitus is a chronic disease characterized by a relative lack of insulin or absence of the hormone that is necessary for glucose metabolism. The chronic hyperglycemia of diabetes is associated with long-term damage, dysfunction, and failure of the eyes, kidneys, nerves, heart, and blood vessels. Diabetes is commonly classified as follows: type 1 diabetes, type 2 diabetes, gestational diabetes, and impaired fasting glucose or impaired glucose tolerance. In type 1 diabetes, an absolute insulin deficiency is experienced due to an autoimmune process. In type 2 diabetes, the insulin resistance or deficiency is related to obesity and a sedentary lifestyle. Gestational diabetes is glucose intolerance with its onset during pregnancy or first detected during pregnancy. Impaired fasting glucose and impaired glucose tolerance is characterized by hyperglycemia at a lower level than what qualifies as a diagnosis of diabetes. In this condition, symptoms of diabetes are absent, but newborns are at risk for being large for gestational age. During pregnancy, diabetes is typically categorized into two groups: pregestational diabetes and gestational diabetes. In pregestational diabetes, an alteration in carbohydrate metabolism is identified before conception. This includes both type 1 and type 2 diabetes. In gestational diabetes, the diabetes develops during pregnancy. The maternal metabolism is directed towards supplying adequate nutrition for the fetus. In pregnancy, placental hormones cause insulin resistance at a level that tends to parallel the growth of the fetal placental unit. As the placenta grows, more placental hormones are secreted. The woman with glucose intolerance or diabetes during pregnancy cannot cope with these changes in metabolism, resulting from insufficient insulin to meet the needs during gestation. The effects of diabetes on the mother during pregnancy include hydramnios, gestational hypertension, ketoacidosis, preterm labor, stillbirth, hypoglycemia, urinary tract infections, yeast infections, and difficult labor. The effects of diabetes on the fetus during pregnancy can include cord prolapse, cardiac problems, neural tube defects, skeletal deformities, increased size of the fetus, preterm birth, fetal asphyxia, intrauterine growth, perinatal death, respiratory distress syndrome, neonatal hypoglycemia, and childhood obesity. A glucose challenge test is usually performed between week 24 and week 28 of gestation. The normal values at 1 hour should be less than 180 milligrams per deciliter. At 2 hours, it should be less than 153 milligrams per deciliter, and at 3 hours, less than 140 milligrams per deciliter. In addition, fasting blood glucose levels should be less than 92 milligrams per deciliter. For many women who develop gestational diabetes, dietary modification is the general foundation of treatment. More women die of heart disease, stroke, and other cardiovascular diseases than men, yet many women do not realize that they are at risk. Every minute, an American woman dies of cardiovascular disease, and more than 1 in 3 women is living with a cardiovascular disorder. Congenital heart disease now constitutes nearly half of all cases of heart disease encountered during pregnancy. Classic symptoms of heart disease mimic common symptoms of late pregnancy, which include palpitations, shortness of breath with exertion, and occasional chest pain. Women with heart disease are at risk for other complications such as heart failure, arrhythmias, and stroke. Their offspring are also at risk of complications such as premature birth, low birth weight for gestational age, respiratory distress syndrome, intraventricular hemorrhage, and death. Tetralogy of Fallot is a congenital defect involving 4 structural anomalies: an obstruction to pulmonary flow, ventricular septal defect, dextroposition of the aorta, and right ventricular hypertrophy. Women with this condition during pregnancy will often be hospitalized or put on bed rest after the 20th week of pregnancy. Oxygen therapy may also be necessary during labor and birth. Atrial septal defects, or ASD, are congenital heart defects involving a communication or an opening between the atria with a left-to-right shunting due to greater left-sided pressure. This causes arrhythmia in some women. The treatment of atrial septal defect includes blocking agents. Ventricular septal defects, or VSDs, are congenital heart defects involving an opening in the ventricular septum, permitting blood flow from the left to the right ventricle. Complications include arrhythmias, heart failure, and pulmonary hypertension. For women with this condition, rest with limited activity is recommended. Pregnant women having patent ductus arteriosus suffer from an abnormal persistence of an open lumen in the ductus arteriosus that exists between the aorta and the pulmonary artery after birth. This results in an increased pulmonary blood flow and redistribution of blood flow to other organs. Women with this condition may be helped by a surgical ligation of the opening. Subsequent problems are minimal after surgical correction. Mitral valve prolapse is a very common condition in the general population, occurring most often in younger women. Leaflets of the mitral valve prolapse into the left atrium during ventricular contraction. Usually, improvements in mitral valve function due to an increased blood volume and decreased systemic resistance of pregnancy allow a woman's body with this condition to tolerate the pregnancy well. Most women with this condition are asymptomatic. However, some women may experience occasional palpitations, chest pain, or arrhythmias, possibly requiring beta blockers. There is usually no special precautions that need to be taken during pregnancy. Mitral valve stenosis is a common chronic rheumatic valvular lesion that can cause during pregnancy, which can cause pulmonary edema, pulmonary hypertension, and right ventricular failure. Most pregnant women with this condition can be managed medically using diuretics, beta blockers, and anticoagulant therapy. Women with this condition may have activity restriction, reduction in sodium, and potential bed rest if the condition is severe. Aortic stenosis is a narrowing of the opening of the aortic valve, leading to an obstruction of left ventricular ejection. Women with mild disease can tolerate the hypervolemia of pregnancy. With progressive narrowing of the opening, cardiac output becomes fixed. Most women can be managed with medical therapy, bed rest, and close monitoring. Peripartum cardiomyopathy is a rare congestive cardiomyopathy that may arise during pregnancy. Multiparity, age, multiple fetuses, hypertension, an infectious agent, autoimmune disease, or use of cocaine may contribute to its presence. The development of heart failure in the last month of pregnancy or within 5 months of giving birth without any pre-existing heart disease or identifiable cause. Diuretic therapy, vasodilators, and inotropic agents may be able to assist pregnant women with these conditions. Non-pharmacological approaches include salt restriction and daily exercise. Cardiac decompensation refers to the heart's inability to maintain adequate circulation. As a result, tissue perfusion in the mother and the fetus becomes impaired. The signs and symptoms of cardiac decompensation are as follows: shortness of breath on exertion, cyanosis or a blue coloring on the lips and nail beds, swelling of the face, hands, and feet, jugular vein engorgement, rapid respirations, abnormal heartbeats or palpitations, chest pain with effort or emotion, syncope with excursion, increased fatigue, and a moist, frequent cough. Chronic hypertension exists when the woman has high blood pressure before pregnancy or before the 20th week of gestation, or when hypertension persists for more than 12 weeks postpartum. The classifications of blood pressure are as follows. A normal blood pressure is 120/80. Hypertension is between 120 to 139 systolic, with a diastolic measuring 80 to 89. Mild hypertension has a systolic blood pressure measuring 140 to 159, with a diastolic of between 90 and 99. Severe hypertension is when the systolic measurement is 160 or higher with a diastolic of 100 or higher. Treatment for women with chronic hypertension focuses on maintaining normal blood pressure, preventing superimposed preeclampsia or eclampsia, and ensuring normal fetal development. Once the woman is pregnant, antihypertensive agents are typically reserved for severe hypertensive patients. During pregnancy, the respiratory system is affected by hormonal changes, mechanical changes, and prior respiratory conditions. These changes can cause a woman with a history of a compromised respiratory system to decompensate during pregnancy. Worldwide, the prevalence of asthma among pregnant women is on the rise, and pregnancy leads to a worsening of asthma for many women. Maternal asthma is associated with an increased risk of infant death, preeclampsia, intrauterine growth restriction, preterm labor, preterm birth, and low birth weight. These risks are linked to the severity of the asthma. In other words, the more severe the asthma, the more these risks are increased. Asthma is an allergic type of inflammatory response of the respiratory tract to various stimuli. It is also known as a reactive airway disease because the bronchioles constrict in response to allergens, irritants, and infections. Asthma is characterized by persistent symptoms of bronchoconstriction, including breathlessness, chest tightness, cough, and sputum production. In addition, the constriction and inflammation of the airways produces thick mucus that further limits the movement of air, making breathing difficult. Both the woman and her fetus are at risk if asthma is not well maintained during pregnancy. When a pregnant woman has trouble breathing, her fetus also has trouble getting the oxygen it needs. Severe persistent asthma has been linked to the development of maternal hypertension, preeclampsia, placenta previa, uterine hemorrhage, and oligohydramnios. Women whose asthma is poorly controlled during pregnancy are at increased risk of preterm birth, low birth weight, and stillbirth. Tuberculosis. A person becomes infected with tuberculosis, or TB, by inhaling the infectious organism, which is carried on droplet nuclei and spread by airborne transmission. The lung is the major site of involvement, but the lymph glands, meninges, bones, joints, and kidneys can also become infected. Women can remain asymptomatic for long periods of time as the organism lies dormant. Pregnant women with untreated TB are more likely to have an underweight infant, an infant with a low APGAR score, and perinatal death. The newborn is at risk of postnatally acquiring TB if the mother still has an active case of TB at the time of birth. Therefore, prenatal diagnosis and effective treatment of the mother are essential. The World Health Organization recommends that the treatment of TB in pregnancy should be the same as in non-pregnant women, with the only exception being streptomycin. Streptomycin should be avoided in pregnancy because of its ototoxic effects to the fetus. Anemia is a reduction in red blood cell volume and is measured by hematocrit levels, or a decrease in the concentration of hemoglobin. This results in a reduced capacity of the blood to carry oxygen to vital organs of the mother and the fetus. Iron deficiency anemia affects 1 in 4 pregnancies and is usually related to an inadequate dietary intake of iron. A woman who is pregnant often has insufficient iron stores to meet the demands of pregnancy. The clinical consequences of iron deficiency anemia include preterm delivery, perinatal mortality, and postpartum depression. Fetal and neonatal consequences include low birth weight and poor mental or psychomotor performance. The clinical symptoms of iron deficiency anemia include fatigue, headache, restless leg syndrome, and pica eating behaviors. The goals of treatment for iron deficiency anemia in pregnancy are to eliminate symptoms, correct the deficiency, and replenish iron stores. The Centers for Disease Control and Prevention recommend routine iron supplementation for all pregnant women, starting at a dose of 30 milligrams per day, beginning at the first prenatal visit. Sickle cell anemia is an autosomal recessive inherited condition that results from a defective hemoglobin molecule. It is found most commonly in African Americans, Southeast Asians, and Middle Eastern populations. Sickle cell disease occurs once in every 500 African American births and once in every 36,000 Hispanic American births. 1 in 12 African Americans have some form of the sickle cell trait. Women with sickle cell disease during pregnancy can have more adverse maternal outcomes, such as preeclampsia, eclampsia, preterm labor, placental abruption, intrauterine growth restriction, and low birth weight. Autoimmune disorders are a group of more than 80 distinct diseases that emerge when the immune system launches an immune response against its own cells and tissues. Autoimmune disorders may cause mild insidious symptoms that may come and go or may be debilitating with high mortality. Two distinct types of autoimmune diseases occur: localized disorders, which target specific organs such as the thyroid gland and Hashimoto's thyroiditis, and Graves' disease. Or they can be systemic disorders affecting multiple organs. Lupus disease is a chronic relapsing autoimmune disease of the connective tissues that can affect various organs such as skin, joints, kidneys, and serosal membranes. Lupus symptoms may include swollen joints, extreme fatigue, oral ulcers, skin rashes, and sensitivity to sunlight. Lupus is a complex disorder characterized by periods of relative inactivity and periods of disease exacerbation or flare-ups. A pregnancy with lupus is prone to complications, including flares of the disease activity during pregnancy or in the postpartum period, as well as preeclampsia, miscarriage, stillbirth, intrauterine growth restriction, and preterm birth. Active lupus nephritis poses the greatest risk. The recognition of lupus flares during pregnancy may be difficult because the signs and symptoms may mimic those of pregnancy. Multiple sclerosis, or MS, is a chronic inflammatory, demyelinating autoimmune disorder of the central nervous system. In early MS, autoreactive T cells cross the blood-brain barrier, attacking the myelin proteins, leading to inflammation and demyelination. As the inflammatory process continues, repeated injury results in a progressive neurodegeneration. Uncomplicated MS does not have adverse effects on fertility, labor, or birth. The focus of MS therapy during pregnancy is to prevent clinical relapse and postpone the neurodegeneration and subsequent disability. Current medications include anti-inflammatories, immunosuppressants, immunomodulators, and a variety of complementary alternative therapies, such as vitamin and mineral supplementation, homeopathy, botanical products, and antioxidants. Rheumatoid arthritis is characterized by joint inflammation and progressive disability. Rheumatoid arthritis is one of the most chronic autoimmune disorders. Rheumatoid arthritis primarily affects synovial joints and tissues of the hands and feet, but any joint can be involved. Over time, bone and cartilage are damaged by the chronic inflammation process, resulting in joint deformity and loss of function. Luckily, in about 3/4 of pregnancies, the symptoms of the disease lessen. Most women experience relief in the first trimester that continues throughout the pregnancy. Rheumatoid arthritis does not adversely affect pregnancy outcome. Unfortunately, for most women, rheumatoid arthritis returns after the 3rd or 4th month postpartum. All pregnant women should be screened for sexually transmitted infections and should be treated if possible. Maternal infections of syphilis increase the risk of premature labor and birth. The newborn may be born with congenital syphilis, jaundice, rhinitis, anemia, intrauterine growth restriction, and central nervous system involvement. Pregnant women with gonorrhea will usually be asymptomatic. However, in the newborn, it causes ophthalmia meatorium through infection acquired by vaginal birth. All newborns receive mandatory eye prophylaxis with tetracycline or erythromycin within the first hour of life. Chlamydia is an infection associated with infertility, ectopic pregnancy, spontaneous abortions, preterm labor, preterm rupture of membranes, low birth weight, stillbirth, and neonatal mortality. The infection of chlamydia can be transmitted to the newborn through vaginal birth, causing the neonate to develop pneumonia or conjunctivitis. All pregnant women should be screened for chlamydia at the first prenatal visit and treated with erythromycin if infected. Human papillomavirus, or HPV, is an infection that causes warts in the anogenital area. These warts may grow large enough to block vaginal birth. Fetal exposure to HPV during birth is associated with laryngeal papillomas. Trichomonas is an infection that produces itching and burning, dysuria, strawberry patches on the cervix, and vaginal discharge. Infection of the newborn is associated with premature rupture of membranes and preterm birth. Pregnant women with trichomonas can be treated with a single dose of metronidazole. Each year, approximately 1 to 7% of pregnant women acquire cytomegalovirus or CMV infection. Of these, about 30 to 40% transmit this infection to the fetus. The risk of serious fetal injury is greatest when maternal infection develops in the first trimester or early in the second trimester. Between 10 and 15% of congenitally infected infants are acutely symptomatic at birth, and most of the survivors have long-term complications. Cytomegalovirus is the leading cause of hearing loss and intellectual disability in the United States. Pregnant women acquire cytomegalovirus disease primarily from sexual contact, blood transfusions, kissing, and contact with children in daycare centers. It can also be spread through vertical transmission from the mother to the child in utero, during birth, or through breastfeeding. The virus can be found in virtually all bodily fluids. Cytomegalovirus infection during pregnancy may result in abortion, stillbirth, low birth weight, intrauterine growth restriction, microcephaly, deafness, blindness, intellectual disability, jaundice, or congenital or neonatal infection. Most women are asymptomatic and don't know that they have been exposed to CMV. Symptoms of cytomegalovirus or CMV in the fetus and newborn is known as cytomegalovirus inclusion disease, inclusion hepatomegaly, thrombocytopenia, intrauterine growth restriction, jaundice, microcephaly, hearing loss, chorioenteritis, and intellectual disability. Approximately 50 million people are infected with genital herpes in the United States, and 1.5 million new cases are diagnosed annually, including 1,500 newborns. About 1 in 4 pregnant women is infected with genital herpes, although most do not know it. Fortunately, only a small number pass the infection on to their newborns. Hepatitis B infection during pregnancy is associated with an increased risk of preterm birth, fetal distress during labor, meconium peritonitis, low birth weight, and neonatal death. Newborns infected with hepatitis B are likely to become chronic carriers of the virus, becoming reservoirs for continued infection in the population. Pregnant women are also at risk for developing varicella when they come in close contact with children who have an active infection. Varicella during pregnancy can be associated with severe illness for both the mother and her newborn. If contracted, some pregnant women are at risk for developing varicella pneumonia, which may put them at risk of a life-threatening ventilatory compromise and death. If the mother develops varicella rashes close to her due date, the fetus can have a 20% chance of death. Maternal infection is preventable by a preconception vaccination. Thank you for watching.